Buloh. Next is Dr. Premila Thevi Gobalakrishnan, she's the head of the OSH unit in Hospital Kajang, and Dr. Norshamimi Sahidan, the head of the OSH unit from Hospital Sungai Buloh. So welcome to all the panel members and participants to this webinar hosted by my seminar. This will allow the panelists to make the presentations on the given topics. Then we can go on to the Q&A later. If the participants have got any questions at the end, you can put it in the chat box and I can bring it forth to the panel members. Okay, without further ado, I think I would like to invite Dr. Kuldip to make her presentation.
A very good afternoon, Dr. Arul and respected colleagues. I'd like to give a short, as what mentioned, experience and best practices during our management of pandemic in Hospital Sungai Buloh. Okay. Okay. Since as an introduction, just like to start from our first wave or the very first case that Hospital Sungai Buloh received. It was on the 25th of January 2020, where the number of COVID-19 patients actually increased drastically from then on. So hence, after which, when the cases came in, it took some time for ministry and because we were seeing the cases coming in, and then ministry actually declared Hospital Sungai Buloh as COVID-19 hospital for Klang Valley. As we all know, this is an unprecedented medical and managerial challenge for us at that point of time. So at that point of time, so basing on this, a COVID-19 pandemic preparedness strategy was developed, and we had to develop also a committee to for the preparedness of this whole pandemic. We actually appointed our preparedness committee for this pandemic preparedness strategy. As we all know that Hospital Sungai Buloh is actually 620 bedded multidisciplinary specialist hospital developed or established in 2006. It is the center for infectious disease in the country. And in addition, we also have our Pusat Kawalan Kusta Negara or PKKN as a satellite facility, right? So basing on the fact that we have these two hospitals in the same compound, so it gives us some opportunity of more space compared to any other hospital. So what we did at that point of time, we kept a fast pace of learning, adapting on an hourly basis. In fact, it was so dynamic that next step also sometimes what we talk now would change the next hour or next minute. So we had to get everyone in the hospital to come to cooperate together with us. So most of the time what we did was we called for a meeting to talk and get cooperation from each and everyone in this hospital for a common purpose. Yeah. So everyone in the hospital actually sat down, and we sat down to discuss and to get teamwork and the trust and understanding from everyone that this is something new and we all have to come together and for the same purpose. Yeah. So it is something that we ourselves sometimes didn't know whether what we were actually doing is in the right direction or not. So the teamwork and the cooperation from each and everyone helped us to prepare for this emergency and an unprecedented event, which together we had to sit down and think and brainstorm. And with all that cooperation given to me and the support given to me, I think we were all together able to actually maneuver in the right direction. So as a hospital director, I had these directorates: medical, surgical, clinical support directorate, and management directorate. This is how in the hospital the directorates go and the organization structure. So the main objective is to share how the organizational changes took place during this preparedness in managing COVID-19 cases in our hospital. So drawing the approach, we also just remembered some of the approaches we took during the H1N1 pandemic, the MERS-CoV epidemic, and the hospital management developed a COVID-19 preparedness strategy with the 6 perspectives in mind. So as in any pandemic, we must know communication is very important, or any event of disaster, communication is the most important thing. So communication in all levels must be conducted well or taken well and understood well by everyone. So the most important thing is the commander also must be one person. If there are too many people, then the organization would not, or the people in the organization would not know who they would want to listen to. So this control must be there in terms of communication and one commander. So the first thing what we did was to get teamwork from everybody and started to actually come from department responses. We have moved on to the hospital response, and hospital response is actually the ID response here, infectious disease response. Okay, so we no more was in departments now. We are under the hospital management now. Means it's a flat organization. So we pool all the resources together and getting the good support from all department and shifting from department response to hospital response and eventually to infectious disease response was the first step we took. So in this way, we are able to pool all resources together under one flat organization, and we are able to get teamwork from everybody with proper communication and with clear communication, proper, clear and communication. And we build trust between all the organization and all our heads of departments and every member in the department. We got trust from them and teamwork from them. I think that is the one that actually made us to succeed in this whole handling, because we had to communicate through medical dental advisory committee, yeah, and we had to sit down and brainstorm together, get ideas from everybody, and all of the ideas we actually put into our strategies, yeah, okay. Second strategy was to scale down clinical services stepwise. If we do not scale down, then as we started, our cases came in single digit. As the week went on, it came in double digit, triple digit, and at one time it came as a ward load, one ward load. Okay, that's how we started: single, double, triple, and then one ward load. So what we need to do was to scale down clinical services stepwise by reorganizing all the surgical and medical services, involving scaling down electives and temporary cessation of emergency that required intensive care, because we were preparing for the worst to happen. We were preparing for the worst. So with this way, we had no choice, but at that point of time when cases were coming in very strongly, we had to decant our inpatient clinical services, you know, because we have to give way. We have to, because we need the space in the ward. We need the ward space. So stabilizing our inpatients and decanting of inpatient clinical services via specialist to specialist referral to all surrounding hospitals, So that's exactly what we did. When we saw that the cases were filling up one ward, we had to prepare the next ward. And by the time we actually went back home from our work, we actually prepared 1 or 2 wards, because we don't want that any patients coming in and suddenly don't have bed, because we want to anticipate our load. As we went on, we not only anticipated our load, but we also anticipated the kind of patients we are receiving. Because we have to see at that point of time, our cases are more stable or they are more ill. Because if they are more stable, then we know they will require ward space. If they were ill, then they definitely require either a critical care area, that means an ICU bed, and we had to be ready in every sense in terms of our equipment, in terms of our manpower, trained manpower. And at all this time, we were not only decanting patients, but we were also working parallelly in different areas like infection control, training manpower. We were looking at our resources. All was running all at one time, parallelly. Nothing was one after the other, all parallel. In our preparedness committee, or Jawatan Kuasa, they call it Jawatan Kuasa Kesiapsiagaan COVID-19, we had to have different tasks for every leader in different areas, the task for leaders in different area. Because we had, to start with, we not only had Hospital Sungai Buloh, we also had PKKN, our leprosy center. So our Kesiapsiagaan committee, or our preparedness committee, was 2 committees, but one main Jawatan Kuasa, where we had a responsible team for the leprosy center as well. So, okay. Next, what we did was, because we became a flat organization by now, so we expanded our ID and critical care services. So everyone in the hospital came under the hospital preparedness. So preparation of hospital response for all critical care service to be concentrated. To be concentrated into accepting COVID-19 case, which involve preparation of specialists and wards and intensive care beds. So by this time, we have actually vacated most of our wards, or decanted most of our wards in different floors. That is the medical floor, surgical floor, ONG and PEDS floor, the multidisciplinary plus neurosurgical floor, and our floors that are above it is also the first class floors on floor 8 and floor 9. So hospital response has taken place with the expansion of ID and critical care services. By now, we have also prepared all our ICU beds with ventilators, because as we said that we were preparing for the worst. So as our cases keep on increasing and our wards kept on filling up, so we have to look at space, how to step down cases that are already recovered, right? So that's when our leprosy center became very handy. So in that way, we were able to use our space to the best of our ability at that point of time. And we also formed teams of manpower in Hospital Sungai Buloh, at the same time in Institute Latihan, at the same time in leprosy center, So we also had to scale down specialist outpatient clinical services. Now you'll ask me why we have to scale down this. Because as more and more patients or come into the hospital or to use our services, we are worried about infection, introducing infections to staff, to staffs. So scaling down of all other outpatient service to reduce infection rate and to mobilize resources, because all our clinic staffs, actually nurses and all, we could mobilize into the wards. That's why we had to reduce our services in areas that were not important at that point of time. So scaling down of all other outpatient services to reduce infection rate, and to mobilize resources into COVID-19 care. So we have to pool all our staffs, our manpower, our doctors, our nurses, and specialists even from other departments. We have to pool everyone for the different tasks that we can do during this point of time. So pooling of manpower and pooling of resources at this point was very important, as it came directly under the hospital now. So this is where the direct control of resources. So we have to put the resources all under the hospital management to make sure that we can actually pool resources for handling this preparedness. And we had to also request for greater budget, because as this is unprecedented, we needed more resources to manage this unprecedented event as it went along. So according to our workload, we had actually requested for a greater budget, and also required more human resource and equipment and facilities to bed management. And also we had to manage our data daily. From the data that we had actually a CPRC, Crisis Preparedness and Response Center at the hospital level, to actually collect our data daily. And it will be actually posted on our WhatsApp chat, where we had 3 or 4 WhatsApp chat. One of it was our WhatsApp chat that showed the data daily. So from the data that we had, we can then see where our resources are lacking, and immediately we can actually request, or we can arrange, and therefore we will be able to be prepared better. Yeah. So direct control of resources in terms of what is required was manpower, all the equipments in the ICU, in the wards, with all new wards that were open. Within, I think, 2 months only, we have opened numerous wards even in our leprosy center. And opening wards is not just like that. We need the manpower, we need the equipment, and we need all the resources to be there to run a ward. So doing that, actually, it was such a challenge actually. In short time, opening up ward and getting all the resources ready, it wasn't an easy feat anyway. So I don't know how we did it, but we did it. It is teamwork, basically. It's all teamwork. It's teamwork, is getting everybody to work together with you, with the trust of your leadership. I think they all came together, and we were actually working hard towards all this. And everybody learned along the way. Everybody learned along the way. Yeah. So actually the hospital advisory committee, the medical dental advisory committee, restructured the pre-COVID management into a flat hospital organization structure based on the need of COVID-19 crisis. So at the end of it, as I said, when we started with medical dental advisory committee. We sat down, we had meetings, discussions, we brainstormed, we came out with a lot of solutions, and finally we agreed to some, and then we just moved forward. And for whatever little learnings that we had, we improved on it daily. In fact, it was very dynamic, because whatever we experienced, we improve on it daily, and we would not repeat what was, what we have learned, we would have improved. And we went on confidently, and everyone was committed and had the passion to carry on, and they were all energetic to carry on, because daily we were also having motivation. We were also giving motivation to our staff, and we kept them going. And for very good things, little good things that they did, we keep praising them so that they have the energy to go forward, because this is not easy. It's like working long hours, it's working continuously, and working on something that you don't even know what's next, because it's so dynamic, yeah. So we had some of our staffs who actually came in just in a very short notice, and they did very well. Surprisingly, they did very well. They were well, I mean, of course, what I used to do is, I used to sit in this same room that I'm sitting now, I think from morning till night, like, you know, advisor, and I used to get meetings and groups coming in to ask me what next to do, and I would just sit down and discuss, and we will straight away make decision, and we move. We did not stop and say no, fear or something. We just have to go. We can't wait for things to happen. We had to just, the word is just go. We have to do it. That's it. You know, so this was the actual place that we used to sit and discuss. I think from starting the day and till the night, we sit down here, discuss, and if we need to move around to see something, yes, we will move around. But we tried to keep our movement a little less, because we had to make sure that there's no overcrowding, or, you know, we had to make sure we have bigger rooms to discuss, not in a confined room. We had to make sure that we open all the doors. So when we discuss, we wanted to make sure that among us also, every day there was a reminder about making sure we follow the SOP, and making sure that all our staffs are properly trained, and making sure they understood the disease or the virus per se. So we had side also, we used to give a lot of talks to different groups, you know, of our staffs, every level. In fact, Dr. Shaimi was the main one, used to give talk. Dr. Suresh used to give talk, and Dr. Benedict, and of course, a lot of my staffs, you know, give talks on the various aspects. And we kept on teaching our staffs as well as we went, you know. So of course, a lot of fear was there. We had to form a committee, a psychological first aid committee also, to alleviate fears first from our staff. We also had the patient group. We also have the staff group. And I think with all these different task groups that was formed, who acted differently, like Dr. Shaimi himself, he was the main OSH person. He used to actually take care and actually train together our staffs with the infection control team, and give a lot of talks on how they can go around, and how they have to take care to follow all the SOP. Infection control also did very well. They really made sure that everyone followed the SOP. And of course, our PFA also had to work hard. Psychological first aid group had to work hard to alleviate fears from all our staffs, our patients. Because when we first started, we even had patients running away from the ward. And that was really something that we never saw before. I mean, patients running away from ward, you know, how it becomes viral. Just the moment press comes to know, it'll just be viral. And that's a real challenge for us, you know, because of this virus that is very something that is new. So everybody had the fear, and they come so unprepared, and they get caught, or rather got stranded in the hospital, and they can't go back, and they are stuck, like, you know, they came with nothing. Little did they know that they will be caught here, and they cannot go back. So at one point of time, we were actually also functioning, sort of inverted commas, inverted commas, something like a hotel. You know, we used to give them their basic things like toothbrush, towel, you know, things that they need to use, comb, and they didn't even have a phone. Here and there, we used to, we have no choice. When we first started, we had to borrow them phone, or get them a phone that is a second-hand phone somewhere which is lying in the house, put some card and give them, because they don't have anyone to communicate with, and they're depressed if they don't tell their family, you know, at the back of their mind, the family, everybody, family is so important. So they need to communicate. So we were like, not only like a hotel, at the same time, something like quarantine center or prison, they said, you know, because we don't let them go. We don't want them to breach the infection prevention control procedures. So they have to be with us, bear with us, and we definitely understand their emotion. We understand what they need. We know that what is working on their mind, that they need to talk to somebody. However, how much sometimes we try to help, but there was still some who wanted to still run away. So many at times we were actually working around the clock, and even with our security did a great job. Most of the time they had to help us so much to take care, make sure nobody runs away and nobody breaks the infection prevention control procedures. So a lot of these challenges that we face in the beginning, the first few months, we face a lot of challenges. We had to actually do a lot of teaching to our staff. We have to talk a lot to our patients, but a lot of it with a lot of, of course, we have to take care of our staff to make sure that they wear their proper PPE and all that before they actually come in contact with any patient. Even at that point of time, there were a lot of things that were not clear. When we started with, nothing was very clear. So of course, we also along the way, we were learning how to handle this, and thank God that we are more lucky, in fact, Hospital Sungai Buloh, because we have our excellent ID team with us, who was all along with us, guiding us of how the nature of the virus. And as I said, nobody knew what it was, but along the way and very dynamic, we were just learning and learning and learning. That's what made us, yeah. Okay. This is the COVID-19 Hospital Response Organization. So this is all the teams that work together. Yeah. You see, if you notice, infectious disease and critical care response team. Yeah. All right. So we had the bed management unit, which is a very important unit because they will tell us how our bed situation in the whole hospital and also in the leprosy center. So when we had the leprosy center, we had one bed management unit there, and we had one bed management unit in this hospital. After later sometime, when we needed more space, we also went on to our training center nearby. And this training center is under Ministry of Health Malaysia. And then we also had another bed management unit there. So 3 bed management units have to coordinate all the beds within or under Sungai Buloh response, COVID response, yeah, Hospital Sungai Buloh COVID response. So we also have a hospital's screening center, which was in the emergency. Rather, we had to find more space, so we had to go near the forensic department, yeah, and we have psychiatric and mental health who did psychological first aid. We had lab services, which is always, hidden, but they're so important people. Without their test results, I think nothing can move, yeah? So these are the unsung heroes at the back. And our infection control team, yes, all around the clock, they're making sure that infection control practices was all practiced according to the infection control procedures. And of course, forensic also had another big challenge of learning how to handle these bodies and how to get it approved, in the state of how to get it approved about how to handle the bodies and the proper SOP, yeah, in managing the bodies, right? And of course, security, as I say, when we first started, without them, it would have been impossible. Patients had so much of fear. We had patients trying hard to run away, and believe it or not, more to say, but Chinese New Year time, a lot of people were all on holiday. So we had shops that when we wanted to do something for our hospital, it was all a challenging task because shops were closed. And yet patients running away, we wanted to actually get our number system to be fixed, but we couldn't. So true, but we had to, one time we had to put a padlock on the door. So, but it's true, at that point of time, that was our challenge, just temporary measure. And once we got it fixed, of course, we removed that. But these are the challenges we face even during that time itself. So The other thing is information technology also, because our amazing number of wards open, they had such a challenge of fixing the numbers that they had to fit on the data that is required, right? Engineering and housekeeping, they just had to make sure that they are prepared for the type of, what they say, the structure that is required out of the, this kind of virus. You need to have a lot of barriers, so that we are not in direct contact with the patient. So they have to do work over the hours and had to prepare the ward according to the advice of our infectious disease consultants. So at that point of time, a lot of help we got from engineering in not only refurbishing our leprosy center. Some of the wards were actually closed and we had to open within a short time. So we need to refurbish the wards. Not only refurbish, we have to make new toilets and bathrooms to, to cater for the numbers that we had. In a very short time, thanks for their cooperation given also. And pharmacy, as usual, they were the most important department. They had to make sure the PPE, the resources and the drugs and all were enough for our numbers of patients. And our clinical research center also was working around the clock as we churned out our data. They were also helping us to with some graphs, that could give us some direction or forecast for what is going to happen next, because in terms of numbers and in terms of how the virus is going is also important, because it's like a guideline for us, to see how our management, we can improve our management, or numbers, how the numbers would go, some kind of forecast that we can get. And public health and contact tracing, of course, we had to, our unit Kesihatan Awam or public health unit had to do contact tracing from the patients that were admitted to us. They had to get the proper history, very detailed history, and then they have to pass the history and the numbers to our state public health. And that was another challenging thing, because it's not so easy. At one point of time, number of patients that get admitted also increased over days, yeah. So as usual, the administrative and management was like working like 24 hours. Whenever we had a call, we had to handle it fast enough to deliver the messages and to deliver the information, timely delivery of the message and information must be timely, to allow even our state and ministry to make proper decisions timely also. So most of the information that we had to give it on time, and that was our crisis preparedness and response center worked around the clock. We had the crisis preparedness and response center. We have team working around the clock, looking at the information and data and giving the data at morning, afternoon and night, and round the clock, what I mean, so that we could see the number of patients admitted and our ward load. And from there also we can also gauge the number of resources that are required in terms of either PPE or drugs, or our making sure that resources are enough. And every day we had charting of our resources, of our resources, and we need to know how much of manpower required. If manpower is coming from outside, we also had to prepare for their stay. We have to make sure our staffs get their food. We had to get food from them from the hospital, prepare the food. We got the approval to prepare food for our staffs working in the wards and everywhere in critical areas in the lab and other areas, to make sure that they are taken care as well. And also, I think, we tried our best to see what we could do for our staff. And all medical and surgical services, their medical officers, their especially some of our specialists from other departments, other than medical, also assisted us, especially in that, roster, for example, our consultant orthopedic, he helped us in making the roster, yeah, for the specialists and MOs working around the clock for COVID response team, yeah, COVID response team. And as I said, we had everyone coming together for this. It was not just the ID. No, it is everyone, right from the admin to other departments and other than medical, all coming together to making sure that we come together in this response as a team. The commitment was really applauding, really. Really, I must say that without them, it wouldn't have been possible. Yeah, wouldn't have been possible. So if you can see the number of beds during COVID-19, in our main building hospital itself, we had 560 beds, yeah? And in the leprosy center, at that point of time, we had 403 beds. Today, I must say we came up to 600 beds already, yeah? Today, as of today. If I say main building hospital Sungai Buloh, today also we came up to 600 beds. I'll tell you why in a short while. And for IL KKM or Institute Latihan KKM, at the moment we are using 2 blocks. So it's about, if you double up the capacity or double occupancy, it will come to 600 beds. So of course, the bed number is more now. At that point of time, that was the bed number that I'm showing now, 2163, right? So if I said, why our bed number increased now? Because our load in this third wave is even more compared to, in fact, the load today we are seeing is like the one we were seeing in the second wave today, right? So our load is equal to, at the moment with this third wave, now is like as we were in second wave. So load now is much more, much more. The volume is more, the volume is more, yeah, the volume, yeah. So our pre-COVID, if you notice, our pre-COVID ICU, we had only 42 functioning beds, you know. So during COVID-19, our ICU beds, we increased to, we makeshift and repurpose certain areas, and we got 108 bed capacities. So that you can see 40, 80, about 2.5 times lah, yeah, our capacity. So that's amazing, right? Okay. So a lot of things were repurposed, makeshift, and a lot of my staffs have actually put, we all put our heads together to come up with a lot of creativity, and we made sure that all were following the certain standards that were required. And we also needed to ensure there's uninterrupted oxygen supply, supplies. The top up was increased from alternate day to daily supply. Yeah? ICU facilities were revamped into makeshift green zone by blocking air supply from the main ICU, and by erecting additional walls and doors with unilateral airflow. So these were some of the makeshift and repurposing that was done during that time. As I said, this is a specialist and a subspecialty hospital. The design, it's not designed to be ID hospital, yeah. It is makeshift, and it was repurposed during this point of time, during this pandemic, to actually help us to maneuver and accordingly as we went along, as how we learned as we went along. And we also, of course, not only learned here, we also were referring to other countries at that point of time. We were looking at how China did, how Korea did, how Japan did, and how the rest did. So we had we had to keep ourselves not only managing the hospital, but also to learn what was happening in the other side of the world or the globe, because we cannot, we have to see what they have learned, and from their experience, we try to improve. When we went along, we tried to improve. Yeah. Of course, there were a lot of discussions even within the hospitals with our ID consultants, which we learned from them, and we did accordingly, as per advised. So this was the graphs that we saw at that point of time. Yeah, maybe I give Dr. Isrin. Can you explain the graph? Yeah.
Hi. Hi, I'm Dr. Isrin. So today I'm going to explain, this is just a graph from the search using our first search during January until May. So as you can see, actually Hospital Sungai Buloh, the total of cases in Malaysia is actually increasing during March, April and May. And the admission that we cater is actually 1/3 of the cases in Malaysia. So what Dr. Kuldip explained about the preparedness in Hospital Sungai Buloh is very important for us to prepare in such a short notice and fast changes in the administrative to cater all these patients that come in a very short notice. So as you can see, because of the nature of the COVID-19, that we need to cater the patient in a longer period of time, not in 2-3 days like in dengue, but in COVID, we need to admit the patient for at least 10 to 14 days until they are negative. So there will be like a backlog, because the admission will become in buses, but then the discharge will only come 1 or 2 discharge per day. So the planning is very important for us. This is just a statistic that shows the admission that we need to cater versus the discharges. So the opening of beds and critical beds needs to be planned very carefully and thorough. Okay, so this is just a conclusion. As a conclusion, hospital worldwide actually were challenged by the shortage of bed and reduced resources, not just Sungai Buloh. Right now, I think Sabah has faced much more greater challenges, that they're really short of bed resources, human resource, but they have to make use of this. So this is why planning is important, to maximize and to utilize all the things that we can, so that we can provide more to the patient and prepare more, so that we can have like a better preparedness for the enemy to come, you know. So by using these 6 key strategies in Hospital Sungai Buloh, we still stick to this, the flag organization, and using the 6 key strategies to overcome these challenges, and we hope this wave also we can go through it. Yeah, Dr. Kuldip, with a very smooth and smooth sailing management for this time. I think that's all from us. So this is just a recommendation last time. So good teamwork, flat organization structure, ensuring resources kept in the optimum level, and continuous manpower training are the key elements for hospital preparedness for COVID-19 pandemic. Okay, this is just a quote. Management is about arranging and telling. Leadership is about nurturing and enhancing. By Tom Peters. Thank you.
Okay, just to add a bit more, at the end of it, I like to say, whatever said and done, there are 2 or 3 points that we need to stress on this. So at the end of it, most important is communication. In pandemic, if we can communicate clear towards all our staffs who are together with us in this challenge, and we can get their understanding, we can get them to come together as a team, and we can listen to them as well, and get their trust and commitment towards this challenge, and being together and getting the trust, commitment, I think it really takes away a lot of issues, and we can actually go smooth, because we know we are together, and we are stronger together as well, right? And And as communication goes, as I said, too many commanders also cannot. We need one commander who can actually lead well. Of course, we can listen to everyone. That's why the meeting, discussions, the teamwork all need to be together. But there must be one commander who can lead with taking everybody's ideas and making sure that whatever that is directed is to the the challenge is communicated well. Yeah, is communicated well, and he must seep down. He must seep down, and of course we must also know if anything we have to turn back, we can come back again and rediscuss. It's not necessary that first time may be right or wrong, right? We have to learn as it goes, because this is something very new. You know, we have to know that it is not an easy feat. We have to learn, and we have to adopt and adapt along the way we go. I think that's the main thing. So with that, thank you very much.
Thank you, Dr. Kuldip. It's good to hear all those stories coming from the ground. All those experiences, good to hear all those things. If our next presenter, I'd like to invite Dr. Premila to for your presentation. Thank you.
Okay, Carmela, can you share? Yeah. So before that, thank you very much and good afternoon, everyone. Thank you, Dr. Kuldip and Hospital Sungai Buloh team for sharing how you guys handle COVID-19 pandemic. And actually, we as a OSH team, if you see, Hospital Kajang is one of the screening hospital. We are not the COVID hospital, but we are the screening hospital. And we always liaise with Dr. Shamimi from OSH Hospital Sungai Buloh to get opinions, and he will be always helping us out. And we also have a team, Dr. Rosnawati, who is in charge of JKN OSH team. And now I'll be sharing something about management of healthcare worker during COVID-19 pandemic. This is actually prepared by CPRC Hospital, Ministry of Health, by Dr. Hanisla. So this is based on Annex 21, and the version is the updated version, which was updated on 13 October 2020. This is the recent one. So I'll be only focusing on certain points because of time factor as well. Okay, next slide, please. Okay, if you see, we are living in a new norms. That's what we call as new norms. So what is important when it comes to especially healthcare workers and hospital is we practice the SOP. There's no point we telling public we have to do this, we follow SOP, wear your mask, practice social distancing if we don't practice it in hospital, because the virus is everywhere actually, especially in hospital as well. So if you look at it, what we encourage is practice of physical distancing at least 1 meter apart. Usually last time what rounds will be a group of doctors and group of nurses, but now we have reduced it. Each cubicle will have designated nurses and doctors. By this way, we are actually reducing the numbers, or I would say we would actually make we are encouraging the doctors to practice social distancing. So where else we will be looking into a nurses station, pantries. Those days we will be like, pantry is something we will be looking forward. You know, every time we want to have a chit chat, we have a tea, or we have our lunch together. But nowadays, sadly, but that's the best for everybody, we limit the number of people that can enter pantry. On-call rooms, prayers room, and waiting in common area, we make sure that there is a 1 meter distance. Okay, if you look at the next slide, please. We also encourage our healthcare worker to always practice hand hygiene. Carmela, next slide. I think Carmela, can we move on to the next slide? Okay, so hand hygiene is very important. Okay, what we will do is before touching a patient, before any procedures, and after any exposure risk, and after touching a patient, and after touching patient surrounding. These are something that we have to, as healthcare workers, we have to look into this as well. Another more another important norms that we have to practice is use of PPE. We have to have know the right use of PPE. The donning and doffing techniques are very important, and we would like to thank infection control teams from all the hospitals who have been actually working on this. And there's a guideline for this actually when you are handling patient, what type of PPE that you need to use, and there's a circular that have been going on. Next slide. Okay, so now we will be talking about healthcare worker. When do you say the definition of unprotected exposure? Okay, when the healthcare worker was not on any recommended PPE, because there are recommendations when you are seeing a patient, triaging a patient, when an AGP procedure is being performed, there are recommended PPEs, there is a guideline for that. Okay, so when the healthcare worker was not on a recommended PPE for the activity or scenario during the exposure, for example, not wearing a 3-ply mask while examining a patient, okay, in the clinic, or not wearing appropriate PPE while doing a nasal pharyngeal swab procedure, CPR and other procedures as well. So like I said, there is a guideline for what type of PPE need to be worn. Okay, the next will be eyes or mouth or mucous membrane are exposed to patient bodily fluid. For example, when we are attending a patient and patient is coughing, okay, mainly respiratory secretion, blood, stool, vomit, and urine. So of the COVID patient, that means you are considered unprotected. Sometimes, like I said, when you are examining a patient with COVID-19 who is confirmed with COVID-19 and they are coughing, although you are wearing a mask, but your eyes are exposed. Sometimes, you know, the saliva can actually, you are exposing your mucous membrane. So this is considered as unprotected. Okay, next slide. Okay, now we'll talk about close contact definition. Okay, what is a close contact definition? Okay, so if any unprotected exposure of their mouth, eyes, or mucous membrane to the bodily fluid, like what I said just now, or if an cumulative unprotected exposure during one work shift, example, breach of PPE, say you are attending a patient but you are not wearing a mask or appropriate PPE for more than 15 minutes and less than 1 meter distance, you are considered as a close contact to a COVID patient. Or if any unprotected exposure, example, breach or breach in any appropriate PPE while present in the room when AGP is undertaken. Okay, so for example, what are the AGP kind of procedures? CPR, okay, intubation, extubation, bronchoscopy, nebulizer, and sputum induction. So when you are present in AGP performing room, so N95 is needed. You can't be only wearing your face mask. That's why there is a guideline where we will be, there is a guideline that will recommend what type of PPE need to be worn at certain procedures. Okay, next. Okay, when we consider infectious period, so when we are doing contact tracing, say we have, for example, we have a patient who we were not sure and then suddenly turned out to be positive, don't be surprised. In Hospital Kajang, we had cases that come in for maybe CCF, and later we found out that patient was, doesn't have any URTI symptoms, but found out that patient was having COVID-19 positive. So what kind of contact tracing need to be done? Okay, when will the patient considered to be infectious period? 48 hours before symptom onset until 14 days after the symptom onset. For example, if I have URTI symptoms, say sore throat, that means I have been considered infectious 48 hours prior to today. Okay, and if for asymptomatic patient from the first positive test, sometimes they are asymptomatics when they have the first test positive and until the 14 days of the first test positive, they are considered infectious. Okay, next. Okay, exposure risk of healthcare worker to COVID-19 is divided into 3 categories, which will be high risk exposure, medium risk exposure, and low risk. I'll be talking about it in the next slide. Next. Okay, if you see, high risk is when unprotected exposure and close contact with a COVID-19 patient during the infectious period with no source control. What we mean by no source control is patient is not wearing mask although you are wearing mask, patient is not wearing mask, okay, or unprotected exposure while present in the room when AGP was performed on a COVID-19 patient. For example, nebulizer, like what I just said just now, intubation, extubation, you are considered high risk. While medium risk is when unprotected exposure and close contact occurred with a COVID-19 patient during the infectious period with good source of control. Example, what do they mean by good source of control is when patient is wearing a mask, you're considered a medium risk exposure. And you will be fall under the low risk exposure category when there is a brief interaction, less than 15 minutes, more than 1 meter, and protected exposure while in close contact with COVID-19 patient with a good source control, means patient is also wearing mask and the use of eye protection. That's why face shield is also important. Okay, next. Okay, if you look at this risk assessment, what does OSH personals do is, OSH doctors and OSH, what we will look into is, when there's a case, we have to do contact tracing. Okay, when there is a contact tracing done, that's when we will use this high, medium and low risk exposure. Why? Because we need to actually to see whether the healthcare staff need to be excluded from work for how many days. For example, if you fall under high risk or medium risk, you need to be excluded from work at least 14 days. So imagine many healthcare workers that falls under this category. 14 days is like, is quite a long time. So that's why we keep telling our healthcare workers, wear the appropriate PPE, wear your mask, wear your face shield, wear the PPE according to what is recommended by the guideline. So if you look, what this diagram is basically is telling is to actually categorize patient. When high risk, they have to be quarantined. High to medium risk need to be home quarantine. 3 swabs will be taken. But when you fall under the low risk, actually you do not need to be home quarantine. And you do, if you have symptoms, then we will swab you lah. So what OSH actually is always telling our staff is, PPE is very important. Hand hygiene is very, very important. And also when you have patients, make sure your patient is wearing their mask. Even say when you're examining a patient, tell the patient wear the mask properly, because that will actually help us with management of healthcare workers as well. Okay, next slide. Okay, this is the slide that I have been explaining about just now. This will be when how do we resatisfy our healthcare workers to be actually whether they can continue to work or they need to be home quarantine. Next. Okay, recommended monitoring for all 3 categories. Healthcare worker with medium and high risk exposure will undergo active follow-up by OSH, means we will be calling them daily to ask about their symptoms, while healthcare worker with low risk exposure will undergo passive follow-up where they self-monitor. If they have any worsening of symptoms, they will call our OSH team. This is basically one of the approach that is being used by Hospital Kajang. Next. So asymptomatic healthcare worker being household contact or having close contact with the suspected or probable case of COVID-19. For example, if a healthcare worker is staying in a house, same household of someone who is being suspected of COVID-19, what we will do is we will exclude the healthcare worker from work until that their maybe spouse or their family member or even their housemates first PCR results to be negative. Why? Because we don't want any unnecessary exposure. Yes, the person will be, what does this quarantine means? When you say you need to be home quarantine, doesn't mean you can share the same bathroom or same room. It should be designated room with a bathroom, okay, and they shouldn't be even coming out of the room. That's what we mean by home quarantine lah. So what are we doing with healthcare worker that stay in the same house? Because we are not sure whether the person is COVID positive, but the person is being investigated, means we will tell the healthcare worker, look, you have to exclude until your spouse or family member or even housemates first PCR result have to come back. If it is negative, then you can return back to work. Next. So what we are trying to say is healthcare worker with history of COVID-19 infection who has recovered and discharged from hospital after day 14 and retested positive is not considered infectious. Okay, and she can continue to work if she or he is asymptomatic. Okay, based on current evidence, recovered COVID-19 patients who are later tested positive do not represent reinfection, so hence they are not infectious. Thank you. Next. So these are the references that have been used by the CPRC. Next. Thank you.
Okay, thank you, Premila. Next, we'll move on to a presentation by Dr. Shaimi. Shaimi, you can proceed.
Good afternoon, everybody. I'm Dr. Shaimi. I'm the head of OSH unit, as I've been introduced by Dr. Kuldip just now. I think from one talk to another talk, what we've seen across the board is that communication is key. Communication is key in managing healthcare workers, managing a hospital, managing a pandemic. Like Dr. Premila mentioned just now is that we communicate a lot. I call her as well, not just she just called me. We talk to each other. Me and Dr. Kuldip, we talk to each other a lot as well. Can I get my slides up? Are my slides up yet?
We're having a slight technical difficulty there.
Just waiting for Camila.
Okay, she has to restart the computer.
Oh, no. Okay.
Sometimes, so I think you can just share your experiences with the time while we are waiting.
Sure. No problem. I've given this talk many times before. So I'll start by talking about a bit of a background of what OSH Sungai Buloh has experienced so far. As opposed to what Dr. Premila has been talking about, it's more towards proper OSH management. What I would like to talk about is more towards the structure and role of OSH in a hospital setting. As we all know, OSH is not very popular before this. Not all hospitals actually even have an OSH unit prior to this pandemic. But nowadays, I think about 85% of government hospitals, KKM hospitals, have their own OSH unit. Can't say the same about private hospitals, private settings. They might consider developing their own OSH unit in the future. So in terms of my talk, first I'll be talking about our background, what we faced, and then we had experience of what we've tried to do. And then from that on, we were tested by having our own cluster in Hospital Sungai Buloh. This cluster might have been might have reached the news. People might have been reading about it as well. And then what we did to control the cluster, bring the number of the cluster down to a minimum, and also our strategies that came forward after the cluster that happened as well. So it's something that we can learn and adapt to other hospitals as well. As a background, we've had our first screening done in February. And then from the screening, we had our first massive contact tracing done in March. Subsequently, we had our first non-occupational related positive healthcare worker in March as well, late in March. And then we had our big cluster which happened around mid-April. But the cluster lasted for about a week before we managed to stop it, and that was about mid of April as well. Finally, the last positive healthcare worker was discharged on 27th of April. Okay, so our prevention strategies, number one, once we get our slides up, it will be better to see this, is that number one is the declaration and screening of our staff. So any staff going into COVID wards need to declare their comorbids, whether they have any kind of illness beforehand. It could be asthma, it could be diabetes, it could be something as being on steroids, being immunosuppressed or immunocompromised. They will have to declare beforehand, and OSH will screen through all the names of the workers, and we will relocate them accordingly. So those who are allowed to go inside COVID wards are usually those with the top bill of health, we would say. And then because of shortages over here and there, like Dr. Kuldip mentioned just now, we would relocate some of those staff who would be considered high risk into lower risk areas. Okay. Secondly, and quite important as well, is education. At the time itself, although COVID-19 was particularly new, without a lot of knowledge, people would be afraid to go into these wards. What we had to do was we had to educate our staff. Education came in through various ways. We had to invite our infectious disease consultants to give talks. We had a good liaison with our PFA team to prepare them beforehand, before going into the wards. And we also educated them on proper donning and doffing techniques before going into these wards. There was an assessment done. We had assessments, impromptu assessments, and also we held re-education training courses for them, just so that they would be prepared to go in and confident about the PPEs. Apart from that, the education also comes in terms of covering the grounds of our workers around the hospital as well. We held awareness campaigns through posters, and also we had competitions like video competitions, so that everybody would be aware of how to be prepared, and also aware about the 3 C's and 3 W's, and everybody would be always adhering to this, to the campaigns. Subsequently, we had to create a bubble. Okay, so by creating a bubble, we want to create a clean bubble, meaning that our hospital consists of positive patients but non-positive healthcare workers. So we want to create these healthcare workers a bubble, a clean bubble, so that they can come into this clean bubble, be exposed to the patients who are positive, but in a positive environment, meaning they are clean, they are in the proper PPE, whether it be inside the ICU, whether it could be inside normal wards, whether they were working as a radiologist, they could be working as a counselor going into COVID wards. All these people would be going in with proper PPE, and this is how we maintain our clean bubble. Okay, so another way we had to do this was to maintain the clean. All right, here's my slide. Could we go down to slide number 7? Right, just before this. The one before this as well. One more up. One more up, please. Oh, no, you're going down. Can we go up? Yeah. All right, so I was talking about creating a safe bubble. Another thing that we had to do was to minimize entry points into the hospital. I'm not sure about the other hospitals, but Hospital Sungai Buloh is blessed with a lot of parking space. So our parking lots are all around us. The situation is that the parking lot doesn't lead into one pathway into the hospital, and therefore we have a lot of entry points into the hospital. The problem was that it was hard to sort of sieve through who is healthy and who is not healthy to walk into the hospital. So we created a new system to declare health online. Each departments were responsible to monitor their staff, and they have to do this on a daily basis. The only problem with this was to get our staff to adapt to this and do it daily as a new norm. And this also was reliant. The problem with the system was that it was reliant on the knowledge and the truthfulness of the healthcare worker. As we know, some workers are very rajin. They, even though they are demam, they got sore throat or cough, they still want to come into work. So the problem was with it, we wanted them to stop coming in. As we've learned from our cluster that happened here in Sungai Buloh, was that the number of contact tracing that needed to be done, the number of healthcare workers who had to be quarantined, when a worker comes to work when they are sick versus when they are not sick is significantly different. Okay, so we're still struggling, we're still working very hard to get everybody to adapt to this new norm, but we are working hard with all the HODs of each department and also sisters and matrons and penilias to make sure their staff goes through the daily health screening. Okay, next slide. For Sungai Buloh, we created this liaison officer system. For short, we called it the LO system. This system was developed by OSH. Then subsequently, when we were talking to China on how they managed each department in the hospital, especially in Wuhan during their biggest outbreak time, how did they manage their healthcare workers in each department? It was about the same, only the name was different, but they had this system which reflected what we had in our school days, which was a class monitor system. So every ward, every area, let it be radiology or even each wards in physiotherapy, each of these areas had their own class monitor. So these class monitors will monitor each worker so that they don't come into the workplace, especially if they are feverish or asymptomatic. So the good thing about this is that the strength of this is that OSH will always know who's sick, because the LOs will report to us, and what we will do next is we will call up the healthcare worker and we will screen. We will screen them whether they are needed to do swab or not. If they need to do swab, let's say they are we've called them up and they're certified their risk to be higher, we will ask them to go to our swabbing center and get swabbed. The results will be also traced by OSH, and we will inform the staff and also their department on the next step. So this is good because report and intervention is done immediately. Okay, so by intervention I mean we do the quarantine immediately. This saves us from having to swab a whole lot more people if a certain healthcare worker turns out to become positive. The only issue with this was that the system was reliant on a single person, our class monitor, usually the sister of the ward or penyeli of the area, and it became burdensome as well. As initially we started, we had 1 ward, 2 wards, then we had 4 wards. Eventually it became more than 20 wards in the main building itself, and then we had a whole lot more in PKKN and ILKKN. So it was a big task for OSH as well. Next slide, Zah. All right, so following that, we came up with an idea to develop an OSH call center. What happened is that the staff were exposed outside in the community, they could be exposed inside the ward as well, and they wouldn't know what to do next. Let's say there was a breach in PPE, and they weren't sure whether it was a proper breach or not proper breach. They wouldn't have anywhere to go. This could happen in any hospital actually. And what we did was we created this call center, which is sort of like around the clock access for all staff to ask questions. And as the OSH call center is manned by our trained doctors, the risk stratification can be done immediately. And subsequently, these staff, sometimes when they only have questions, end up being quarantined and anyway. So we save our other workers from being exposed by creating this OSH call center. It's like a one-stop area for everybody to call. They also decide on surveillance swab as well for symptomatic staff, staff who could be proper when they're wearing their PPEs, who have been staying at home, haven't been exposing themselves in public, could have the problem of having URTI symptoms and wouldn't know what to do. They could go to a GP, they could go to a KK, but most of the time our staff would call up OSH and ask us what to do. As OSH in Sungai Buloh, we are the gatekeepers of who is allowed to be swabbed. We will decide on the swab decision. And then subsequently, OSH call center, one of the biggest strengths of having an OSH call center is that we can combat short staffing. Let's say, for example, there's a significant number of staff exposed to a patient who wasn't positive in the ward, came in for, like Prem said just now, probably CCF, and then turns out after swabbing, it became positive. So what we do is that usually there's a whole list, depending on how many days the patient has been in the ward, of our own staff who needs to be swabbed. And by creating our own OSH call center, we are able to manage how long each staff is going to be quarantined based on their risk level. And this OSH call center as well, they compile data, the whole list of everybody who has ever been swabbed in our hospital, and there's no tolerance at all in the OSH call center, be it HOD or you are a datuk here or datuk there. There's no loophole for you to escape swabbing. So it's very thorough. Next slide, please. From OSH point of view, as we all know, OSH, the bread and butter of OSH is usually having to do with workplace assessments. So we do a lot of audits of our COVID and non-COVID related areas. We manage the work processes they do. We sometimes alter some steps that we feel like are not suitable to apply during COVID times. At the same time, we also liaise with our counseling unit and also our psychiatric unit to manage mental health of our staff through MHPSS. We also suggested for most departments to create small teams. This is to minimize cross-exposure. We've triggered almost all departments to create their own contingency plans. This is in case some departments have a high number of quarantine staff. We do PPE compliance audits in certain areas of the hospital in conjunction with infection control as well. And in most areas of the hospital that needed remodeling, we are involved as well in that sense. Next slide, please. So one of the things that we've created in Hospital Sungai Buloh, with the blessing of our pengarah, our director, we've managed to create this alliance a task force, which is an alliance of all the HODs in hospitals and Buloh, and OSH. This is to safeguard, as it says, safeguard the health of our staff. The objectives are to identify our healthcare workers who are not compliant to SOPs of infection control. And from there on, we actually do take warning and disciplinary actions to our staff, and we also monitor the health of all our healthcare workers. Next slide, please. As we can see here, our safe task force in Buloh is checked by our director, and there are two arms to this. One on the left side is our safeguard team, which is the health surveillance team. It's coordinated by myself, and under that we have our liaison officers. As we can see, we've copied Starbucks' name, Venti liaison officer, Grande, and Tall. So these are different levels of liaison officers in each department. So all these officers, liaison officers, will monitor the health of our staff daily. They are also trained to manage how to manage our staff who are exposed. On the right hand side, we have the vigilante team, which is our new norm team. This team is like the policemen of the hospital, but they do things quietly. So we call them the vigilante team. It is coordinated by Dr. Sahidan, which is actually the HOD of the OMFS department. Most of the members in the vigilante team are HODs. The name is purposely kept secret so that nobody knows who is on duty that day doing rounds in the hospital. And they take turns, they have their own schedule, and they will go around the hospital to check to see who are the staff who are not wearing their masks, who are in the pantries with more than 2 people, who is doing rounds but not looking after their physical distances. These are very important in terms of enforcement and also for prevention. Thank you. I think that's my last slide. All right. So no. So not my last slide.
So proceed.
I would like to talk a little bit about what happened in hospitals in Buloh. We had a cluster. It's all very secretive about this cluster. I'm not allowed to talk too much about it. The number, the duration and location, what investigation we did, and the cause are all very confidential. But I can tell you about what we did to stop the cluster. So next slide, please. So when we had this massive cluster with, well, at that time it was considered quite big. And in this cluster, we had a massive amount of people who had to be screened and quarantined. So we had a lot of emergency implementations that had to be done. One of the things that we did quite properly was that we had to close the loop. When we're talking about cluster, when people are talking about breaking the chain, is that we want to close this loop and cut the loop off. So what we did was very quick notifications. So whoever were suspected to have been exposed to a positive healthcare worker were quickly notified. They were either swabbed if they were deemed at the right time, or they will be told to stay at home and not come into work until the right time for them to be swabbed. So this was done at the same time as a rapid risk assessment. So at the time when we tell them to stay at home, we will call them again and stratify the risk category. And from there on, we will decide on whether they need to be swabbed, how many times they need to be swabbed, the number of days they need to be quarantined, and whether they could be released or not. At the time as well, when we wanted to close the loop, we told the whole hospital that everybody who is in said ward working will have to stay there for a whole month. There was no rotation done weekly rotation or 2 weekly rotation, then whether you were a doctor or a nurse or whichever level of healthcare worker. And during this time, we had our team of vigilante doctors to go around more strictly. There was minimum number of areas to congregate. Mask was definitely wajib at that time already. Physical distancing was ensured all around the hospital, and we enforced limitation on number of people in enclosed areas. There was strictly no tolerance to any rule breakers. Quarantining was done properly and fast, and thankfully our loop was cut short after about 7 days. Next slide, please. So what we managed to do was we intercepted the bubble. The bubble was dirty, but we had to go in and take the dirty stuff out. The PFA team went in with us, helped us to keep our spirits of our staff high all the time. ICU admissions were limited at the time because ICU was one of the areas affected by the number of quarantine staff. Luckily, our hospital runs our own swabbing test in the lab, so we were able to prioritize our staff results, and we managed to trace them immediately, and the number of staff who were quarantined was cut short. So apart from this, would like to praise very good communication with our ID team. Was always around us, helping us around the decision making processes, and of course my pengarah as well. There wasn't a time during the 7-day cluster that we weren't talking. I think it was always a constant interaction. Next slide. So from there on, what could have been worked for us was that no decisions were made by ourselves. All decisions were made after discussing with our pengarah and also our ID team. What could have worked was that our fast action to immediately quarantine staff that needed to be quarantined. What could have worked that none of our staff who were positive needed intubation was that maybe our screening processes, our health declaration worked. So only healthy staff were exposed. The PFA team worked really well. All of the staff who were affected by the cluster were kept in high spirits. What could have worked as well is that we immediately closed all congregation areas, including pantries and surau, and eventually we came out of the grey skies with no disruption of service, which was to us very important. And we managed to avoid having to do mass screening of the whole hospital just to capture our positive patients, our positive healthcare workers. So these are things that we thought worked really well for us. Okay, I think that's it.
Okay, thank you.
Thank you. Yeah.
Just would like to inform all participants. Dr. Premila had to leave urgently. He has to attend. Can I have Dr. Kuldip online? Back online, please. Okay. You are there.
Presenting Dr. Kuldip, yeah.
All right. Good. Okay, as you all were decanting the hospital and scaling down services.
Yes.
In labor room.
In labor room.
Yes.
Yes, we did that as well. But at first we have we divided into two, which is the higher risk for COVID. So we have one team there, which is they are fully donning and they're fully equipped with their PPE. And we also have the other team that manage the lower risk for COVID. So initially we have to open two teams. We have no choice. But later on we try to reduce the non-COVID patient because we want to utilize more on the COVID side. ONG.
Okay, if there is a GP, as a doctor in a GP setting, and
Yes.
then a patient came to him, they've done a voluntary swab, and if the swab turns out positive, how does he make a hospital?
How does he make, sorry?
The referral to the hospital.
Sorry?
A
Referral.
GP goes to a GP, a swab done at a GP setting. If the test turns out positive, how is this patient referred to a hospital setting?
I'm actually we are not entirely sure of this, but I think the best way to communicate is to talk to the nearest PKD,
The PKD
because
lah.
which is supposed to be done outside the hospital. Yeah.
Okay. All right. So with all these COVID cases coming in, so any potential medical legal issues cropping up at your center?
Definitely, yes. So
We
definitely
hope not. We
high
hope not.
chance for that. So we always need to have a backup plan, and a very PNC private and confidential must be always main priority for us. So that's why we do ask staff to sign so that they also take care of the private and confidential for the patient, and we also follow our patient and family right policy very strictly this time, because we want to ensure that, because data leaking for COVID patient is very crucial and it can lead to very big medical legal case.
With regards to when you did swab for all your staff and all that, tell me something about the pink wristband.
Something about, sorry?
Pink wristband. Do you all put the pink wristband?
Oh, that one I think better public health. Shahimi, can you?
But the pink wristband is specifically for people who come in from the airport. They're not the ones who are swabbed in our hospital.
So in your swab, you all don't put for the family members.
No.
Okay, I would like to ask the participants any questions you all can put up in the chat box. Or if you can ask the panelists. The panelists can see the chat box. With regards to OSH, so now we've got all our colleagues getting COVID and all that. How about burnout syndrome among staff?
It's definitely something that we are afraid of. We are trying our best to tackle this issue before it even starts, which is why even from the beginning, OSH was working very hard with PFA team, the psychological first aid team, to try and keep burning out at bay. But we do have some issues with some staff who had burnout issues, and we've talked to their superiors. We try to take them out for a while and try and give them some encouragement, and some of them actually go back inside.
Good, that's good. Okay, for the administration, as you all know, the media actually plays a very important role in the pandemic. We have the mainstream media, and now we have the social media. A lot of fake news being viral here and there. Actually, all these fake news affect your administration and eventually patient care. How do you all tackle this fake news going around?
Okay.
We had some issues then with Israel.
Yes, we do. Our PRO and also the communication PRO in KKM level also has been doing a very proactive measures. So once they notice there's a viral or fake news, they will put like any fake, in the KKM Twitter, Facebook, including one of the hospital. Also, we do have a lot of fake news, and they acted it very actively and promptly until the viral, and then people know that, oh, this one is a fake news, So the proactive measures is very important, because we don't want people perception towards the hospital change, and our credibility also will be affected by it.
Yeah, exactly. Anything to add from Shaimi?
I think very luckily the staff in Sungai Buloh were made aware of not to share very exposing stories, or whether from a work experience
Good. Any questions from the audience? I would like to ask one huge question. Are we ready for the fourth wave?
Sorry?
Are we ready for the fourth wave if it comes?
I say bring it on, but I'll let Israel answer that.
Yes, I will second to Shahimi, bring it on, but we always be like one step ahead.
Yeah,
And
we're always planning. Yeah.
the team and the healthcare frontliner attitude and motivation always make us be more prepared than usual. Yes, we're praying and hoping for the best, Dr. Arul.
Yes, definitely. Any final say before we end the forum from Shaimi?
Yeah, I would love for everyone to just remind your family members, your friends, your close circles to keep everybody safe. Try your best to stay away from crowded areas. It's a good advice. It works really well. And they're not just saying 3 C's blindly. These are all backed up by very good numbers. And from what we've seen, it works really well. Okay, so it's best we as frontliners, we can share the message across the board to everybody who's in our circle. Thank you.
Izrin?
So for me, I would like everyone to take care of yourself and your surrounding. Everything also come back to us. It's our decision. It's our I mean like our act like impact the cases outside. So basically, it's not from the government, MCO or MCO or anything. We don't rely on that. We take care of ourselves, our family, our friends, and that's more important.
Thank you very much. Okay, to all the frontliners, you're doing a good job. Keep doing the good job. Please stay safe. And I'd like to return the forum back to the organizers. Amira? Yes, Amira is here. Good.
Hi. Thank you, Dr. Shahimi and Dr. Israel for joining us, and Dr. Arul for moderating. Dr. Premila had to leave.
Yes,
Thank you all for participating. Hope to see you all soon.
okay, thank you, Amira. Bye-bye.
Yeah. Oh my God, I feel so awkward speaking